Matt Roush and Mike Brennan. He's over
And
there.
Mike Brennan,
And
yes.
we're doing the M Squared TechCast today with Fred Brown, our infectious disease expert, who is busier than the proverbial one-arm paper hanger right now, talking to a whole bunch of states and the incoming Biden administration about COVID and our responses to it. So, Fred, first of all, welcome to the program, and we're glad to have a half hour of your time. Thanks again.
It's great to be back. I appreciate the chance to talk to everyone, and hopefully I give you some helpful information.
We're going to send you over a case of 5-hour energy so that you can get through all this stuff that you've been doing here. And that is a local product. One of our Indian American friends actually developed that here in Detroit. So we're buying local.
That's right.
Right?
That's right. That's a good thing. I encourage everyone to do that right now, because a lot of local industries are having and businesses are having trouble. So if you can find a local restaurant you want to support, local bookstore, local retail shop, that's a great chance to do it right now, especially if they have curbside support.
So one of the things that we talked about, what we're talking about during the commercial is I took your advice and didn't do the family Thanksgiving thing in Grand Rapids this year. Just cooked my own turkey. I'm eating lots of leftovers this week. But I was in the minority, it seems. I read that 1 million people flew over Thanksgiving and 6 million people traveled over Thanksgiving.
It was more than that. I heard 70 million people were traveling. When you take 70 million,
70 million
out of 320,
maybe I got bad. Go ahead.
And that's like half what it normally is. But what does that mean? What are we going to see in the next week or two?
Well, it's not going to be good. And of course, we did predict this in our models that, between Christmas and what happens is people, go to the big event. In about 10 days, they become ill. And then about 20 days after that, they kind of create illness in the next generation of people who they've contacted. And usually about 5 weeks beyond that, then you start to get the super spread. And sadly, that's right at about Christmas. And so we're predicting over 3. No, it's just as I think Tony Fauci called it a surge in a surge, and he that pretty much describes what we've got right now, unfortunately. Yeah, and it's just hard to stay away. We're close to we've got the vaccine. We're going to launch the vaccine on the 12th. I'm pretty sure. I'm pretty sure the FDA advisory committee is going to give the go ahead, and I think on the 12th we'll start seeing movement, and we'll see 40 million doses being shipped and 20 million people being vaccinated in the next 3 to 4 weeks.
And I assume the first ones to get it would be first responders, healthcare people like that, right?
Well, we're having a little of an argument over that, actually. So it turned out that the vaccine was a little bit more efficacious than we thought it was going to be. And when you have a super efficacious vaccine, the way to save the most lives is actually to inject the people who are most at risk and most likely to die if they catch the disease, which are the comorbid elderly. Elderly with comorbid conditions, I should say. Things like, if you're over 75 with cardiovascular disease, are a smoker, and have diabetes, and have body weight of
that's kind of like the trifecta there, huh?
Yeah. Then you should.
I guess I need to take up smoking again to increase my chances of getting the vaccine early.
Well, sadly, just 3 of those factors is enough for you to get on the hot list. So if it's super efficacious, that's what you want to do first. We were expecting kind of 50 to 70% efficaciousness because these vaccines technologies haven't been tested yet completely, or haven't been rolled out yet completely to populations this large for coronavirus, which is the first time we've had a vaccine for this disease. So we thought 50 to 70%. If it's 50 to 70%, the people you want to vaccinate first are actually the healthcare workers and the and your high transmitting essential workers. And so now we've got this problem where half of us who've done a lot of modeling say, gosh, we should probably change our sequencing a little bit and move to a group of move to the. I can even show you if you want. I can even show you the analysis that was done.
Sure.
If you're interested.
Absolutely.
I can look that up quickly, and I'll show you exactly what we were thinking about. It's going to take me just a second to find it, if that's all right for you. I will do that, and I'll show you exactly what the documents we were looking at to make this decision looked like. Let me get that for you. If I can hopefully open this up and get it for you. 1 second. So tell me any other questions while I'm looking for this? We can get into
Well,
it.
Christmas. Well, all the holidays. You got Christmas, you got Hanukkah, you got all sorts of
Year's,
end of the month. They're all coincide. Same advice, right? Just stay with your immediate nuclear family, I guess, right, or something like that.
Sadly, COVID does not play favorites with regard to religion and doesn't take any holidays. So as a friend of mine told me, does not observe holidays. And so, you need to, think that through pretty carefully. And the trick would be either you're one of the lucky ones who can get a vaccine, within, in the first 10, 15 days of rollout. But even then, you're only going to have one vaccine when you need a sequence of two. Or you can try to actually self-quarantine. First you test yourself about 18 days ahead of time. Then you self-isolate for about 10 to 14 days if possible. You take your trip, you take a test immediately after that trip, and then you take another test 8 days after that trip. And then if you're at your location, haven't really interacted with anyone, it's extreme. At that point, it is safe to see and visit with people. And if you're taking tests constantly, you probably don't have to do that second. That first 14-day quarantine ahead of 10 to 14-day quarantine ahead of travel. So that would, if you are in that category, or if you're in a vaccinated category, then I'd feel safe. Otherwise, I'd stay home, with your immediate family unit. So let me share with you what we looked at. This is how we thought about allocating vaccines. And this is Dr. Duling. She's one that she and Beth are our fearless leaders. And you can see we're basically trying to balance three big areas. One is the science, the second is implementation, and the third is ethics. And we said, given the science, the ethics, and the implementation, which are the first people who we should vaccinate? And so we looked at the science, and we went through all the papers, and we looked at the implementation, the feasibility of doing this piece. And basically, and then finally we look at the ethics. And you can see that in the phase 1 vaccination, this was the result of the August ACIP meeting, and was reconfirmed by the National Academy of Medicine meeting. You can see that the high-risk medical conditions, the healthcare personnel, the essential workers, adults over 65, you can start to see the size of these populations throughout the United States that we're trying to affect. So you want to try to get an intersection of some of those things, especially the adults over 65 and the high-risk medical conditions. You see that's a pretty big group of people, and the people who are taking care of them and supporting them as essential workers. Once all those things start to overlap, that's where you want to be with your first round. And so we defined all these groups, and we said how big they were, and then we looked at the science, and we said, here is who's going to be most impacted. And so here was the results of some of the science with incidence, with mortality rates of all the different groups, who was most affected. Here's long-term care facility populations. Then we started to look at hospitalization rates with all these different groups, because we were worried about whether we were going to start to fill in, overflow all of our hospitals. We thought that could be possible around Christmas time. We're going to get to that magic number of we could get up to we certainly will hit 3,000 a day, I believe, of new cases, and we make it as high as 5,000 peaks, which would be just a real challenge for some of our hospitals to keep up if it's how they concentrated. And you can start to see the death rate among the different people, congregate settings. We took a look at the skilled nurses. We also looked at prisons and other congregate settings. And so then we modeled everything. We said, look, if we model this, here are the different things that are going to happen, and the incident rates. So if your incident rates are increasing, you're going to have a bigger impact and delta with the over age 65, like I said. So as you start to get higher and higher incidence, if you're able to reduce that transmission with the vaccine, all of a sudden you're going to get a much better impact on the elderly. But it's now originally, if you do this randomly, the number is 8 times. Here it's only 3 times. So some of our models weren't exactly the same, but we're in the same ballpark. Then we looked at averted deaths, and again, you can start to see starting to get significant death aversion by about 4x here with incident rising, incident falling, depending on what the vaccine impact is, right? Then finally, you look at population-wide averted deaths if you have an actual disease-blocking vaccine. And this is actually what we believe we have. We think we have a transmission-blocking vaccine. And you can say here, again, the change is well over threefold. Oh, I'm sorry, is over threefold. Not well over, but it's over threefold. And so we thought, and I thought, based on this, we should be focusing on the over age 65 and healthcare workers. But you can see overall, the group said no. It's pretty much the same. It was statistically significant in my estimation, but not for the whole group voted. We all voted, confidentially before the meeting. And then here's the intent to receive the vaccines. So if you can get the people the vaccines who most need to, are they willing to take it? And you can start to see that, again, we don't see that much differentiation. People who are generally older are willing to, are more likely and more willing to take it. But it's pretty close. Same thing for the kinds of people who are likely to get this, who wanted to get the early allocation. We sure don't want to have to start to flip things around if we're trying to give things to young adults who are going to take this thing at 16%. All of a sudden, you're going to have to, every time, if in this case, 1 in 6 are saying, I'm sorry, 5 and 6 are saying, no, I don't really want to take it now. Thank you very much. Then you have to constantly rejigger your allocation. Meanwhile, if you're at 25, only 1 in 4 saying no, that's a little bit easier to manage. So we looked at those kinds of issues, the feasibility issues, and then you can see. So here's the value and the feasibility of hitting everybody, and you can see that we thought that essential workers and adults with high-risk medical conditions were going to be harder to hit than adults age over 65, just because it's easy. They're easier to find. You're over 65, you're not. Essential workers are harder to define. There's a lot of politics involved in which of the essential workers do you start to vaccinate. Do you do the police first, the fire first, and so on. And then with high-risk medical conditions, we don't have the systems actually to tell us all the time who is in the highest risk. So that's the least feasible of those. And so when you put it all together, science and implementation, you're talking about a pretty even score, right? And so what breaks the tie in our discussion, now we're going to have another meeting about this next Tuesday, but what breaks the tie is what they call the ethics. And here you can see that here are some of the issues about the ethics. And we found, there was a lot of feedback from people, from unions and people who are essential workers who said, gosh, it's not really very fair. We've got to go out and expose ourselves to all sorts of high risk conditions when the elderly should be able to stay inside, quarantine, behave appropriately and stay well. And so as a result of that, you can see that ultimately what we came down to was that this group, if you add up the pluses, the essential workers were suddenly pushed ahead of this group. So you go A, B, C, and so here's what they ultimately recommended. Originally, we just had 2, which was the phase 1A, which is healthcare professionals and long-term care facility residents, and we had B, which are adults with high-risk medical conditions, adults over 65. They've inserted between those two a phase 1B for education sector, food, agriculture, utility, police, firefighters, corrections officer, and transportation. So we've inserted quite a complicated group to actually get to. Adults with high-risk medical conditions over 65 who are in facilities are pretty easy to localize, but the essential workers, again, they're pretty dispersed. There'll be arguments between the different states and jurisdictions that 64 different jurisdictions we're trying to send this out to. So we could have quite a challenge to insert this B suddenly into the situation. So here's how the rollout could look. And you can see we've added also 3 weeks before we get to the general population of this test. And that also is a lot slower than we were hoping, because we have now Moderna and Pfizer and possibly AstraZeneca all coming in January, which is going to be in kind of week 5 period. So it'd be nice to be able to have this behind us and already being into phase 2 if we could. So anyway, those are, I hope, those are some of the things that we thought about, and you can see that we still have some discussion to think through, but anyway, that's what was on the table.
With the 3 vaccines that are moving forward and hopefully available in January, how many total doses are we looking at? Do you know?
Oh, absolutely. Yeah, you're talking exactly what we were looking at. Let me show you what that looks like. If you can bear with me for a second, I think I can go right to it. Yes, I have it up anyway because I've been working on this all day today. Let's see. So it's going to look something like this. Where is that? We'll get that. Here we go. This isn't the right slide. This is kind of looking at how we're going to roll this out with diagnostic products. The slide I was interested in showing you. Oh, here is here. Can you see it now?
Yep.
Perfect. So now this is if everything goes well and we get as many of the vaccines as we think we could have, here's what this whole thing looks like. Basically, what's happened is OWS, or Operation Warp Speed, has created these deals for us, right? And these deals say you're going to get, well, the deals actually look like this. The deals say that Pfizer is going to give us 100 million doses, and we have an option for 500 million more doses. Moderna is going to give us 100 million doses and has an option of 400 million doses. And this is over the next 18 months or so. AstraZeneca, 300 million, Johnson & Johnson, and so on. So you can get a sense of the volumes of different kinds of vaccines we have contracted for. And they come in at different prices. They've got different levels of complexity in terms of management of the cold chain. And importantly for Johnson & Johnson, they're a single dose versus everyone else is a double dose. And we have different estimations about when things are going to move from an emergency use authorization to a biological licensing application, which means it's now generally licensed for use. It's an approval of the FDA versus just an emergency use authorization of the FDA. From that, we can just, if everything's successful and people are rolling out when they say they will, then in January, if you take a cross section here, for example, in December 15th today, from December 15th to about December 28th, you'll only have Pfizer to choose from, because it'll take that much longer for Moderna to probably get approval. I think Moderna, we're going to come out tomorrow. I'm sorry, the 12th. With the 10th with an approval for Pfizer. We probably will come out on the 20th for approval of Moderna. So by January, half of your vaccines are either going to be Moderna or half will be Moderna and half will be Pfizer. In February, all of a sudden AstraZeneca kicks in. Well, AstraZeneca is a really big player. They can do 3 billion doses a year, like Moderna and Pfizer, which only do 1 billion each a year when at full scale. AstraZeneca can do 3 billion now. So they're going to come in, and they've already contracted 300 million doses with us. They're going to be about half of the doses you've got available probably in February. By March, J&J will be approved kind of middle of February. So J&J will be ramping up. And they actually are, have the smallest number of contracted amounts to give us, because they're only a single dose. They only give us 100 million doses, and then they move to free market. And that's what's sort of interesting, because right now we're up here, right? CDC distributes OWS deals, and the jurisdiction, or your state in our case, or a tribal, or if you're part of a tribe in Michigan, they'll do that. They'll allocate based on their own ways of thinking about policy. So first the CDC says, here's how much you get, state of Michigan. And then the state of Michigan Health and Human Services head will take on that amount. And it'll probably be, we're about 10 million out of 330 million. So it'll be, a small percentage of the total amount that is available, 3-4%. And then our job as Michigan is to distribute, right? Well, after about May, June, those deals start to run out. And so all of a sudden, Merck's going to come on in about May, and it won't have a deal. It can go free market right away. So you see all this sort of interesting mix of a free market, an allocated market that's happening, and quite a constrained market initially through April. From April to June, you've got this kind of hybrid market. From June on, it's going to become more and more and more a free market where people will be able to buy their own vaccines by the competitor of their choice, should they want to, or get a free one through the OWS at the time of allocation. So that's
how are they, for instance, in Michigan, how would they be distributed? Through doctors' offices, through pharmacies, through the military? What,
Yeah. So if you're part of the military, it'll be distributed through the military. And OWS says, a as a military and public partnership and private partnership with HHS, the military, and private companies all working together. If you're part of the state of Michigan, you will be told, what you'll do is you'll enter in your details into an eligibility finder that the CDC website is going to be putting up. So it's an interface that you've got. You say, I'm 65 years old. I've got these disease issues. I've got this and this. It's confirmed by your doctor. And then you'll be given basically a draft number, right? And then you use that draft number.
I had one of those before.
Congratulations, you're number 7 million.
Yes, that was a lottery I didn't want to
You don't want to be too high on that number. This
is a lottery where you want a low number.
Exactly, you want a really low number. So and then you'll be able to go to something called the vaccine finder, which will be on the CDC website. You look at the vaccine finder, and it'll say, you should go to CVS, which is right down the street, or you should go to Walgreens right down the street. My guess is that the vast majority of these vaccines will be carried out by what they call multi-jurisdictional parties. Those are groups like Walgreens, CVS, and others. They'll have mobile capabilities. They'll be able to get into the towns. The doctors and the hospitals don't really want to have that many vaccines being distributed in their offices, because, believe it or not, these vaccinator sites, they'll be doing 100 vaccines an hour.
Ooh.
Yeah, you're going to have to be able, and the capacity we're looking for is about 1% of your total population every day.
Wow.
That's how much your max capacity should be. So that would be the
military or the National Guard's involved. I live right next to a National Guard armory, so I'm all set, right? So.
That's right. Well, my guess and my hope is that they'll have mobile units. It'll be nice if it's in large parking structures or big arenas that are covered, because it's going to get snowy and cold and people are waiting, because you're going to have to wait a while as you do for the tests. But if we thought that 1,000 tests a day was hard, wait till you can do 1,000 vaccines an hour.
So we got.
That's why I'm not sleeping anymore. I'm working day and night trying to help all these states work. But it's important work, and I think people are going to be, this is really the game changer for.
But in the meantime, nobody let your guard down, for God's sake, right?
Oh gosh, that'd just be a tragedy, right? You're 5 feet from the finish line, and they come down with COVID, and you're 5 days away from having a vaccine. So it's worth being a little bit patient now, letting this Christmas go. And having a great one next time, and trying to do a little bit of work on the Zoom, try to keep the communication going and traditions going as best you can.
I think I mentioned last week that I saw Dr. Fauci on TV, and he likened it to the cavalry is coming. So don't give up the fight until the cavalry gets there, right?
Yeah, it's worth sort of wearing a mask, because that's sort of the deal we've got. Yeah, if we wear a mask. So I just put together a major, what they call playbook, for free for all the states. So what happened was the CDC came out and said, we want you to create a strategy for your vaccine rollouts. So all 50 states came back. We have 64 jurisdictions. They all came back and said, we're going to do this and this and this, and they all went with a format. And what we did is we reviewed all those states' strategies and reports, and we took the best from all of them, and we said, here's what you really should do on day 1, day 2, and one of the things we tell all the states is, whatever you do, don't try to launch this vaccine in the middle of a pandemic. Try to get your numbers down as much as you can. I think, that's what Governor Whitmer, to her credit, is doing, right? She's trying to keep, we're going up a heck of a curve as it is, but the worst thing we could do is to let that keep right on going after Christmas, right? That we want to bend the curve back down, so in March, when you have max vaccination, at full blast going, we don't create super spreader events of all kinds of people who are out there trying to do their best to get safe. So we're telling them, test a lot, still wear your mask a lot, still distance if you can, and do all the hygiene that we're recommending, because it'll be worth it. I think we're close. We're really close. Saying that it's going to take us a year to roll it all out, but at least we're close to something that is really a backstop for the vast majority of us.
So again, getting back to the holidays, all the various holidays that are coming up very quickly here at the end of the month, don't do family parties and something like that.
No, I know the airlines are super enticing. Go ahead and get a flight and then change it. There's no change fee right now, and so take advantage of that and the low prices. But if you're going to change to something, wait till after your vaccination number is up. We went through that last week. Basically, most of us will probably be vaccinated in a September, November timeframe. And don't forget you have to go through 2 courses generally. Next Thanksgiving, buy your ticket because you can have a good deal and take advantage of it now. But this Christmas, I wouldn't do it. It's just too dangerous, and there's going to be too much COVID around. Even if
I couldn't believe yesterday I saw a cruise line ad for the first time, and they were like, "Break free! We've all waited so long." I'm like, "Oh my God, that's really what I want to do is get out a floating petri dish right now." God. Yeah, a year from now, okay. The only thing I'd have to worry about is norovirus, right?
Get both doses of your vaccine, and you'll be home free. But until then, just be really careful.
Yeah, you might still get food poisoning or a hangover, but that'd be it, right? So
those we have backstops for. The COVID's not quite yet, but we're getting there.
All right, we just got a minute or two left. Anything you want to close with, Fred?
Yeah, I think so. All the states are going to have a big challenge with this. It's going to look pretty good as we start things off. Kind of December, January. It's mostly healthcare workers, most people in long-term care facilities, and then that period, sort of February, March, April, May. That's going to be extremely challenging for the states to manage. In June, I think we'll start to hit a little bit more of a rhythm, but we'll still be challenged. And then by September, hopefully most of us will have at least access to a vaccine and have one dose in us, and hopefully on the road to the next dose. If we do that, we could hit herd immunity by the end of next year, which would be fabulous.
Traditional four-year students love Lawrence Technological University's thriving campus life. But LTU has always met non-traditional students' needs too. Lawrence Tech offers over 100 degree and certificate programs that can get adult students started or back on track. And most of our classes are conveniently offered evenings at our beautiful Southfield campus or online, so you can balance your social, family, and work life even while you power up your career. Lawrence Tech, where Blue Devils dare.